Hello, everyone, and welcome to Orthopedic Surgical Statistics under World of Ortho, my educational platform. This is Cameron Sabat. Nice to meet. I'm a third-year Georgetown medical student. So this first lecture is called Foundations of Statistical Thinking in Orthopedic Surgery. I think it's a must-watch for anyone in medical school who's interested in the field. So I'm going to be real with you. When I first started out in medical school, statistics was the last thing I was thinking about, and I wanted to learn about in orthopedics. I wanted to learn about cool surgeries and not necessarily p-values. But here's the thing: this stuff actually matters way more than I realized, and it's really the foundation of the field in terms of evidence base. So I'm going to show you why over the next 90 minutes, why this is so important. So let me let me start out with a story that happened to one of my colleagues actually on when they were shadowing back in high school. We're in morning conference, and the attending was asking him about a new paper on ACL reconstruction, and he asked, "So, what do you think about their statistical analysis?" And he froze. I mean, he said he had no idea what to say beyond, the p-value was less than 0.05, and these were the groups. But that was really it. I mean, it was a very complex paper. So the attending kind of moved on and spent the next, five or so minutes explaining to the student why the study was, actually garbage despite the significant p-value. And that's when I realized, when my friend told me that story, that if I want to be taken seriously in orthopedics, I need to understand this stuff. And so, no matter what stage you're in, even if you're in high school, this is exceptionally important. So today we're going to build your statistical foundation from the ground up. And I promise no complex math, no formulas to memorize for this first lecture, just practical stuff you'll actually use on rotations in research and when you're trying to impress attendings. So here's what we're covering. First, I'll explain why surgeons actually care about statistics and why you should too. And then we'll learn about, the basic language, like what is categorical versus continuous data. After that, we'll talk about how to describe data, which is basically what you need for any research project. And finally, we'll go through different study types. So when someone mentions an RCT or a cohort study, you'll know exactly what they mean and why that matters. So ready? Let's dive in. So the first of the three parts of this lecture is why statistics matter. And, I'm going to give you three concrete reasons. The first is, not looking dumb on rounds. I'm serious. The number of times I've seen, opportunities arise to share basic statistics from literature is incredible. And so here's what happens. You're presenting a patient with a distal radius fracture. The attending asks, what's the evidence for surgical versus conservative management? And, you scramble and find some paper that says surgery is better. The attending then asks, was that statistically significant? What's the effect size? Was it adequately powered? And if you don't know what those terms mean, you're kind of done. But if you can say something like this study showed a statistically significant difference with a p-value of 0.03, but the effect size was small with only a 5-degree improvement in range of motion, which may not be clinically meaningful, boom, you just went from, looking clueless to looking like a future resident. Second reason is research. So let's be honest, orthopedics is quite competitive, and the average matched applicant has something like 15 research experiences. But here's the secret. Most med students doing ortho research are, data monkeys. And so you collect a lot of data, but you may not understand all the nuances that go through when the statistician performs an analysis. So when you understand statistics, you really become invaluable to research teams. You can help design studies, interpret results, and contribute to papers instead of just being another name in the middle of an author list. And third reason is you'll actually be a better doctor. And this sounds cheesy, but it's true. Every clinical decision in orthopedics involves probability and risk. So, picture this. A 70-year-old comes in with knee arthritis, and do you recommend conservative management, arthroscopy, or total knee replacement? And how do you decide? You need to understand the evidence. And, what's the success rate of each option? What are the risks? And how do those numbers apply to this specific patient? And patients are getting smarter, right? There's Dr. Google, and they Google everything. They come in saying, I read that this surgery has a 90% success rate. You need to know what that actually means. And does it mean that 90% of people are pain-free? 90% don't need revision? 90% are somewhat improved? These details matter. So the next part of my kind of conversation here with you is the types of data in orthopedic research. This is exceptionally important. And this is really the meat of things. We need to understand types of data. This is like learning anatomy. It seems basic and boring, but it really becomes foundational for everything you do. Think of all the information we collect on orthopedic patients, right? Some of it's numbers we can measure, like range of motion in degrees. Some of it's categories, like what type of fracture they have. And understanding these differences is important because different types of data need different statistical tests. So we can start with categorical data. This is the checkbox stuff on forms. And the first type is really nominal data. So nominal just means named categories with no inherent order. In orthopedics, think about fracture classifications for this. When we say someone has a Garden 3 femoral neck fracture versus a Garden 4, we're using nominal categories. And yeah, they're numbered, but a Garden 4 isn't really one more than a Garden 3. They're just different categories, really. Other examples are, surgical approach, anterior versus posterior, hip arthroplasty. One isn't more than the other, or like type of implant, Smith and Nephew versus Zimmer. Again, they're different categories. Gender, race, which extremity is affected, those are all nominal data. Then the second type is ordinal data. And this is ordered categories. This is the classic example in orthopedics is the muscle strength scale. So when you test someone and say they have 4 out of 5 strength, that's ordinal. And we know that 4 is better than 3 and worse than 5, but the difference between 3 and 4 and the same as 4 and 5, not really. That's just an order. And so there's no real, level to that. And then other ordinal categories, like the Kellgren-Lawrence grades for osteoarthritis, grade 4 is worse than grade 3, but it's not exactly 1 unit worse. Pain scales are technically ordinal too. When a patient says their pain is 7 out of 10, is that really exactly 2 points worse than a 5? Probably not. And then the third type is really binary data. This is just yes or no stuff. Did the fracture unite? Yes or no? Did they develop an infection? Yes or no? Did they return to sport? Yes or no? Super simple, but super common in orthopedic research. Now, let's talk about continuous data. This is the stuff we actually measure with numbers. In orthopedics, we measure tons of continuous data, right? Range of motion in degrees, knee flexion to 120 degrees, that's continuous. Surgical time, this case took 87 minutes. Blood loss, an estimated blood loss of 250 milliliters. Leg length discrepancy, so 5 millimeters shorter. And then BMI, bone density, angle of deformity, all continuous. And here's a pro tip for when you're doing research. Always collect continuous data when possible. You can always convert continuous to categorical later, but you can't go backwards. So if you record age as 25 years, you can later group it into 20 to 30 years if needed. But if you only record age 20 to 30, you've lost information. And there's one special type of data that orthopedics loves, which is time to event data. This is like continuous data, but specifically about time until something happens. So time to fracture unit, implant survival time, time to return to work, time until revision surgery. This type of data gets its own special statistical methods called survival analysis, which we'll cover in lecture 3. So let me tell you why categorization actually matters. Different types of data need different statistical tests. So you can't use a t-test on nominal data, right? You need chi-square. And you can't use Pearson correlation on ordinal data. You need Spearman. When I didn't know this, I watched someone present data saying that they used a t-test to compare fracture classifications, and the attending destroyed that person. So, don't be that person. Also, when you're collecting data for research, knowing these types helps you set up your spreadsheet correctly. So, fixing data types after you've collected 500 patients is a nightmare. And so now finally for part 3 of this first lecture, which is about descriptive statistics. So this is basically how we summarize data so it actually makes sense. Without this, you're just staring at a spreadsheet with hundreds of numbers. And so let me paint you a picture here. You're working on a research project looking at surgical times for total knee replacements, and you've got data on 200 cases. And your attending asks, so how long do these cases typically take? You can't just say, list 200 different times. You need to summarize, and that's descriptive statistics. So we can start with measures of central tendency, fancy words for what's typical or what's in the middle. So the mean, that's your average. Add up all the surgical times, divide by 200, simple. But here's the thing about means in orthopedics. They can be misleading. Say most of your knee replacements take 60 to 80 minutes, but you had one absolute disaster case that took, 4 hours because of some crazy complication. That one case can pull your mean way up. So you report average surgical time 85 minutes, but that doesn't really represent your typical case. So, you can drop outliers, but that's really where the median comes in. So line up all 200 surgical times from shortest to longest, pick the middle one, and that's your median. And the beautiful thing about the median is it doesn't care about outliers. That 4-hour disaster case doesn't affect the median much. So when you've got some outliers, which happens all the time in surgery, every case is different, median is often more representative. Then the mode is just the most common value. So honestly, they don't use it much in orthopedics except for categorical data. And, that's like what's the most common type of fracture we see? That's a mode. So here's what separates the med students who get it from those who don't, is understanding variability. So two surgeons might both have average 75-minute knee replacements, but one consistently takes 70 to 80 minutes, while the other swings from 45 minutes to 2 hours. Same mean, totally different variability. So who would you rather have operating on your family? The range is simple, maximum versus minimum. If your fastest knee replacement was 45 minutes and slowest was 180 minutes, your range is 135 minutes. But range has the same problem as mean. One outlier screws it all up. So that's where standard deviation comes in. It's the one that sounds scary but isn't. It basically tells you how spread out your data is from the mean. A small standard deviation means everyone clusters around the average, and a large standard deviation means lots of variability. In our surgical time example, a standard deviation of 10 minutes means most cases are pretty similar. A standard deviation of 40 minutes means huge variability. So here's a practical tip. When you present data, always include both a measure of central tendency and variability. Don't just say average blood loss was 250 milliliters and call it a day. Say average blood loss was 250 milliliters with a standard deviation of 100 milliliters, or median blood loss was 200 milliliters with a range of 50 to 800 milliliters. That gives a much clearer picture. So then we have the interquartile range, and that's another way to describe spread that ignores outliers. You find the 25th percentile and the 75th percentile, and the IQR is the difference. It tells you where the middle 50% of your data lives. It's super useful for skewed data, which we see a lot of in orthopedics. Now, how do we actually present this stuff? You'll see this in every orthopedics paper. So for normally distributed continuous data, that's data that makes a nice bell curve, we report mean and plus or minus standard deviation. So you'll write surgical time was 75 plus or minus 15 minutes. But for skewed data or ordinal data, we report median with IQR or range. So you'll write length of stay was 2 days, IQR 1 to 3 days, or pain score was 3, range 0 to 7. So for categorical data, we use counts and percentages. 45 patients, parentheses, 22.5% developed complications. Let me tell you about a mistake I made. I was presenting research on fracture healing times, just casually with someone, and I noted that the mean was 12 weeks, and the attending asked about the distribution. Turns out most fractures healed at 8 to 10 weeks, but a few took 6 months. So the median was only 9 weeks, and by only reporting the mean, I made healing times sound much worse than they actually were. And, that's when I kind of pinpointed that in the paper. And oftentimes you learn about statistics and research through this trial and error. Here's another practical point, knowing when to use tables versus graphs. Tables are great for exact values, especially when comparing multiple groups, because they get pretty complicated on graphs. But graphs tell the story better. A box plot shows the median, IQR, and outliers all at once. and a histogram shows the shape of your distribution. And when you're reading papers, always look for these red flags in descriptive statistics, means without standard deviations, no mention of outliers, mixing parametric and non-parametric descriptions. That suggests sloppy analysis. So finally, we get to the second to last point, which is study designs in orthopedic research. And this is crucial because study design determines how much we can trust the results. So think of evidence like a ladder. At the bottom, we have expert opinion and case reports. At the top, we have systematic reviews or randomized controlled trials, RCTs. And each rung up the ladder means stronger evidence, but it's also harder to do. And so we can start at the bottom, case reports and case series. A case report is just, hey, I saw this interesting patient. Case series is, hey, I saw 10 interesting patients. In orthopedics, these are super common because, they see rare stuff. Weird fracture pattern, case report. New surgical technique you tried on 5 patient, case series. The problem is there's no comparison group. You fixed 5 weird fractures with your new technique and they all healed. Great. But maybe they would have healed anyway. We don't know. So I'll give you an example. There was a case series of, 20 patients with terrible ankle arthritis who got ankle fusions. 18 did great. And then the authors conclude ankle fusion is excellent for ankle arthritis. But what if we compared it to ankle replacement or even conservative treatment? We don't know. And that's the limitation of these things. So then we move up the ladder to cohort studies. These follow groups forward in time. So you take 100 patients who got an anterior approach hip replacements and 100 who got posterior approach, and then you follow them for years to see what happens. The key advantage here is you're comparing groups. That's going to help a lot of reviewers with your paper. The key disadvantage is that the groups might be different in important ways. And so maybe younger surgeons do anterior approach and older surgeons do posterior, true story. Maybe healthier patients get anterior. These are called confounding factors, and they can totally mess up your conclusions. There are 2 types of cohort studies. Prospective means you identify patients now and move them forward. Retrospective means you look back at old patients. And prospective is obviously better because you can standardize data collection, but it takes forever. So retrospective is much faster, but relies on whatever you got documented in the charts. This is typically what medical students do. Now we have, case control studies, and those work backwards. So you find patients who had a bad outcome, like implant failure, and match them to patients who didn't. And then you look back to see what was different. And maybe the failures were more likely to be smokers or had high BMIs. These are great for rare outcomes. If only 1% of implants fail, a cohort study would need thousands of patients. But with case control, you just find the failures and work backwards. So the downside is you can only study one outcome. There's lots of room for bias in selecting controls. Now, the gold standard, randomized controlled trials. So take your patients, randomly assign them to treatment A or B, follow them, compare outcomes. The randomization is magic because it balances known and unknown factors between groups. But these are really hard in surgery. First, patients have strong preferences. It's like, doc, I don't want to be randomized. I want the minimally invasive option. And second, you can't really blind surgeons to the surgery they're doing. The surgeon knows, I think, if they're doing arthroscopic versus open. So that always introduces bias. So there's the famous SPORT trial, the Spine Patient Outcomes Research Trial, and they tried to randomize patients with disc herniations to surgery versus conservative treatment. But so many patients crossed over between groups that the randomization basically fell apart. Still valuable, but shows how hard surgical RCTs are. At the top of the ladder are systematic reviews and meta-analyses. So these combine multiple studies to get a better answer. And, a meta-analysis might combine 10 RCTs of ACL reconstruction techniques to get a more precise estimate of failure rates. The power here is numbers. One study might have 100 patients, but combining 10 studies gives you 1,000. This can detect smaller differences and give more precise estimates, but, garbage in, garbage out. If you combine 10 bad studies, you just get a precise estimate of the wrong answer. So here's how to quickly assess a study's quality when you're reading, because there are a lot of limitations to all of these. One, really I'd look for who funded it. And so industry funding doesn't mean it's bad, but just be aware. 2 is really how are patients selected. Consecutive patients are better than selected cases. 3, and this is one people don't often talk about, but is the statistician sponsored by industry? Because that can get you rejected by an institutional review board pretty quickly. Also, 4, how complete was follow-up? If 40% of patients disappeared, the results are questionable. 5, were outcomes assessed blindly? The person measuring range of motion shouldn't know what treatment the patient got, because then you're introducing expectations. Then 6, how were the statistics handled? And we'll cover that in lecture 2. So really, the final point I want to kind of wrap up lecture 1 with is the practical applications. So we can pull this all together with a real scenario you might face. This is the kind of thing that comes up in research meetings, and I want you to be ready. So imagine you're working with an attending who has an idea. He says, I've been using this new technique for fixing distal radius fractures, and I think it gives better range of motion than the standard technique. Let's try it, or let's study it. And the first question you really want to ask is, what data are we collecting? Range of motion is continuous data measured in degrees, and that's good. Continuous data gives us more statistical power. But we'll also want to collect patient demographics. Age is continuous, gender is, at least in the research study, sex is potentially a binary variable, and fracture type is nominal if we're using AO classification. And here's where students mess up. They only think about the primary outcome. What else matters? Time to return to work, that's time to event data. Complications, that's binary. Pain scores, that's ordinal. Grip strength, that's continuous. You need to think through all of this before you start. Next question is, how will we describe our results? For range of motion, we'll probably report mean and standard deviation if it's normally distributed. But wrist motion after fractures is often skewed. Some people get full motion back, others get stuck at 50%. So we might need median and IQR instead. Then for our complications, we'll report counts and percentages. 3 patients in the new technique group, 6% versus 8 in the standard group, 16%, developed complications. Now, the big question is, what study design do we want to use? Your attending wants to just report his last 50 cases with the new technique. That's a case series. Better than nothing, but there's no comparison group. So you could suggest a retrospective cohort, look back at the last 50 patients who got the new technique and compare to the previous 50 who got the standard technique. Better, but he only started using the new technique on younger, healthier patients. That's confounding. So the ideal in this case would be RCT, randomized patients to new versus standard technique. But now you need IRB approval, informed consent, and patients willing to be randomized. And you need to calculate sample size. More on that in lecture 2. Here's a real world tip. Start with the retrospective cohort. It's faster, cheaper, and will give you preliminary data. If the results look promising, then propose the RCT. But this staged approach is how a lot of orthopedic research actually happens. And I want to also add another practical issue, which is data collection sheets. So you want to design those very, very carefully. You don't want to just throw stuff into a sheet. I've seen so many projects fail because the data sheet was just confusing. And the statistician reached back and it just, the medical student already moved on. And so for continuous data, you have to specify the units. Don't just write blood loss. Write blood loss in milliliters. Instead of surgical time, you write surgical time in minutes from incision to closure. For categorical data, you got to list all the possible options. And this is a common thing I see in database studies. They don't clean the data right. And so they sometimes eliminate valid categories from the data accidentally. So for fracture type, don't leave it blank. List, extra-articular, partial articular, complete articular. Otherwise, everyone records it differently. And here's the golden rule. Pilot your data collection. Have someone else try to fill out your sheet for 5 patients, and you'll quickly find what's confusing or missing. And vice versa. If someone else is doing the data collection for you, or you've gotten, maybe a college student on board and they're doing it, double check their work, And if the statistician's running a study on NSQIP, check the PUF 2022, data dictionary to make sure that the statistician has recorded all categories and not accidentally dropped any. Because just because a statistician gives you output doesn't mean that it's right or perfect or whatnot. Oftentimes, statisticians come from outside the department. They aren't quite aware of the different procedure types or why you'd want to group certain procedures with those procedures and like list CPT codes in the same category. And so you want to connect the statistician with insights that you got from an actual orthopedic surgeon or a resident who knows what CPT codes, for instance, to analyze. So, key takeaways, wrap up. We've covered a lot of ground today, and these are the key takeaways that'll actually stick with you on the wards. First, statistics isn't some abstract math. So, the language of evidence-based orthopedics is statistics. When attendings discuss treatment options, they're talking statistics. When you read journals, you're reading statistics. When you do research, you're doing statistics. You can't escape it, so embrace it. Second, know your data types. I can't stress this enough. Categorical versus continuous determines everything downstream. How you describe it, what tests you use, how you present it. When in doubt, collect continuous data. You can always convert it to categorical later. Third, you want to always report both central tendency and spread. So mean without standard deviation is meaningless. Median without range tells half the story. This is low-hanging fruit to impress attendings, but most students forget the spread. Fourth, you have to understand the hierarchy of evidence before you wade into these waters. Case series are hypothesis generating. Cohort studies show associations. RCTs show causation. Know what each can and can't tell you, and remember the limitations we discussed. Fifth, when reading any orthopedic study, I want you to ask yourself these questions. What type of data did they collect? How did they describe it? What study design did they use? Could confounding explain the results? And all of those questions can serve you very well in Journal Club. So now, what should you do next? First, in your next clinic, practice identifying those data types. When you see a patient, think about what you're measuring. Range of motion, continuous. Fracture pattern, nominal. Just constantly have these playing in your head. Second, next time you read an orthopedics paper, don't skip the methods section. Look at how they describe their statistics. You'll understand it now. You just keep reading those and you start to develop kind of a pattern of what different study types are looking for, what journals are looking for, what the language is. Third, if you're doing research, use what we talked about today. Design your data collection carefully. Think about your study design options. You'll save yourself hundreds of hours of wasted effort. So in our next lecture, we'll dive deep into hypothesis testing. We'll decode p-values, confidence intervals, and learn how to choose the right statistical test. And we'll also talk about power and sample size, which are crucial for planning studies. But for now, you've got the foundation. You understand why statistics matters, how to categorize and describe data, and how different study designs work. That's more than most third-year med students know, and it's enough to start impressing on your orthopedic rotations. Any questions? Remember, the goal isn't to become a statistician, it's to become an orthopedic surgeon who can think critically about evidence, and today was your first step. Thanks for sticking with me, and next time we'll make you dangerous with hypothesis testing. See you then.